So good morning, everyone. Welcome from all over. We have participants from South Africa, all over all the provinces, although it is hosted in Limpopo. We have participants from Ghana. We have participants from Uganda. We have participants from Kenya, as well as Botswana and Namibia. Dr. Malloy is from Botswana. And Dr. Malloy is actually Dr. Thabo Malloy. He's the head of obstetrics and gynecology in the biggest referral hospital in Botswana, which is Princess Marina Hospital in Gaborone. He is the HOD since 2016 and is also chairperson in Botswana of the National Maternal Morbidity and Mortality Committee. Dr. Malloy, thank you so much for joining us and sharing with us your experience on PPH and the use of the Ellavi in Botswana. I hand over to you now.
Good morning to everyone. Greetings from the home nation of Botswana. I'm going to be brief. Botswana, maybe let me first introduce so that I can put everything into perspective. Let me introduce Botswana. Botswana is a small little country, neighboring South Africa, Namibia, Zambia, Zimbabwe. It's the size of Texas in the US. And most of it in the western part of the country it's semi-arid, like a desert. Hence, you can sort of like appreciate our challenges when it comes to healthcare provision. And what makes it even worse is the fact that we only have about 9 gynecologists in public service in the country, compared to over 50 in private practice. And our national mortality ratio over the last 10 years or so has been on a steady decrease, i.e., between 2016 and 2018, it decreased from 156.6 to about 137.7, and then there was a slight rise around 2019 to about 166. And most of the contributing factors mostly was PPH, like in most countries anyway. And in our setting, most of the patients, they may be referred to Princess Marina already in a very bad state from the distance as far as about 1,000 kilometers from the hospital. So even though in more than 15, 20 years, people were using, for uterine balloon tamponade, they were using the simple latex condom. From 2019 to current, we have been using Ellavi, which has contributed enormously to the reduction of the national mortality ratio. I think the latest one from last year is about from 166, it fell down to about 110 to 120, somewhere there, which is a huge contribution. But most significantly, there's been significant reduction from maternal deaths due to PPH. Our strategy has been very simple. With our unique challenges in terms of shortage of specialists in the country, we have engaged the junior doctors. We have trained them with the use of Ellavi from 2019 to current. This has not only reduced mortality, but it has played a role of reducing the death in transit, that is transportation, because if someone calls you 1,000 kilometers away, then they're able to insert, which is very easy to insert, Ellavi, and then the patient is transported safely to our facility. And by the time they reach, actually, you even wonder why was the patient referred, because you find that there's no longer any bleeding, and we just observe for 12 to 24 hours, then we remove the Ellavi, and the patient is fine, is sent back home safely. Also, we have a serious shortage of blood, so Ellavi has been very handy in terms of reducing blood loss when inserted appropriately for the appropriate indication. So we reduce blood loss and the use of blood. Another factor is that we've also been able to reduce surgical intervention, be your compressing sutures or even more radical, the hysterectomy. So with the use of Ellavi, we have managed to reduce that quite significantly. Maybe as a point of reference to our own facility, because that's where most of our patients get referred to. Surgical intervention has reduced drastically, and we have also reduced, morbidity in the sense of maybe losing wombs, hysterectomies. That has been reduced drastically in the country, and in our own facility. I beg your pardon. But that reflects the entire nation, because most of our patients get referred to our facility. So honestly, Ellavi has come very, very handy to us. Even before 2019, between 2015 and 2019, we even considered using another one, competitive one, but then the price was too much. The government could not afford. Hence, we just continued using the cheapest possible, which was the latest condom. But Ellavi has been cost-effective, produced locally within our continent. So we are very, very, very grateful for that innovation.
Before we move to Ghana, so Prof Qureshi is a lecturer at the University of Nairobi. Hello, Prof. How are you?
Fine, thank you.
Yes, so you can share with us a quick experience on PPH and the use of the Ellavi in Kenya.
Okay, good morning, everybody. Thank you very much for giving me this opportunity to join this meeting and talk to all of you. So I will just give a brief introduction. Our country, Kenya, is in East Africa. We are a population of about 55 million. And in our country, we have a high burden of postpartum hemorrhage, cases that contribute to maternal death. So our maternal mortality ratio is 342 per 100,000 live births. And we have set up in line with what South Africa does, the confidential inquiries into maternal deaths. And the first report that was released in 2017 noted that about 40% of all the maternal deaths that had occurred in our country were as a result of obstetric hemorrhage. And our estimate is that about 3/4 of those, that obstetric hemorrhage was due to postpartum hemorrhage. There was an update of that analysis done in the year 2020, which has noted that the number of deaths that are occurring from hemorrhage, which is antepartum and postpartum hemorrhage, is actually almost 50%. So we do have a large burden of maternal mortality, which results because of postpartum hemorrhage. And of course, the next cause is due to hypertensive disease. So what are we doing as a country? We are very happy that we were able to join the trial that was introduced and given. We were given the opportunity by PATH together with Ghana to carry out a study in 3 facilities in Nairobi County. Nairobi is the area, and we had our largest tertiary hospital, which is Kenyatta National Hospital, a mission hospital, St. Mary's, and another government hospital, Mbagathi. And we introduced the Ellavi UBT. We did training with all the health workers, and then we first through webinars and then hands-on training, and then we availed the device. And our providers were very happy to use it in comparison to the condom balloon tamponade, because it's all assembled and very easy to use when a patient is having hemorrhage from uterine atony. So we now are looking forward to rolling it out for general use. It is registered in our country by the Pharmacy and Poisons Board, and hopefully it will be made available in many facilities. We also have a project going on through PATH Kenya office, where there were 2 counties that have had interventions to start to roll it out. So we hope that through all these efforts, we will have more and more use of this device. So we need to put in, a lot of effort, not just the use of the device, but we also need to look at how we recognize postpartum hemorrhage early, how we intervene early. And together with Professor Su, we are also part of another very large trial, which is called eMotive. And we are looking at how to recognize postpartum hemorrhage and put in a bundle approach. So we have a lot of activities going on towards trying to reduce postpartum hemorrhage, trying to recognize it early, trying to put in interventions to be able to ensure that we do not have severe morbidity or mortality as a result of postpartum hemorrhage. So we are very, very happy to have been given the opportunity to have use of this in our facilities, and we look forward to more and more interaction with this device as we also try to roll it out into many parts of our country. Thank you very much.
Again, my name is Dr. Hassan. I'm an obstetrician gynecologist in Ghana here. I also work as a medical consultant with Manjo Clicks in Ghana. Now, when it comes to our experience with the Ellavi, we know that in Ghana for the past few years, there's been some trials going on. There's been some interactions with PATH also. At this point, we are in the rolling out phase. We've started education, training sessions, and people are gaining more and more familiarization with the product. So, but I'd like to introduce Ghana to everybody who is tuned into this production. Now, Ghana is a country located in the West Africa. We get a nickname as the gateway to West Africa. Now, Ghana is a country that comprises of about 30 million citizens. Now, interestingly enough, women within the reproductive ages, roughly from about 18 to 45, they form close to 50% of the population. So it's very important on our side for us to have a clear understanding of the impact of postpartum hemorrhage on the Ghanaian society. We are also it wouldn't be unfair to state that we seem to be plagued with high numbers of maternal mortality. The good news, however, is that from I think 1990 to 2015, there's been a drastic drop. In 1990, we were recording about 740 maternal deaths out of 100,000 live births. I think by 2015, the number had reduced to about 319 out of 100,000. It sounds kind of good, but the problem there is looking at the global picture. Around that same time, the global average for the maternal mortality ratio was about 216 per 100,000 live births. So we still were in a little bit of, we're lagging behind. Interestingly, developed countries around that time had an average of about 12, not 312, not 112, 12 maternal deaths out of 100,000. So that gap between sub-Saharan Africa and the rest of the world is quite significant. It's something that we still need to bridge. So we're also aware that in accordance with the third Sustainable Development Goal, there is a certain portion that speaks about maternal mortality. With respect to the countries, the aim is to reduce maternal mortality to less than 140 per 100,000 live births. I think the last figures that we have are from about 2017. That's when we had the maternal health survey. At that point, we had gone down to 308 maternal deaths out of 100,000 live births. So I'm looking forward to good news when the next maternal health survey comes around, to at least let us know how well we are doing and what else we can do. Now, the other thing of significance here, the other point to note is that we are aware that a majority of maternal mortalities are preventable. In fact, roughly about 75% of them fall under that category. Out of that 75%, postpartum hemorrhage, hypertensive disorders of pregnancy, especially preeclampsia, eclampsia, infections, unsafe abortions, and then other issues to do with pregnancy tend to form that bulk of the 75%. We are also aware that when it comes to postpartum hemorrhage, uterine atony accounts for about 70% of those cases. So what it tells us is that whatever we can do to reduce the incidence of uterine atony can have a significant effect upon the overall reduction in the maternal mortality ratio. In Ghana currently, the two main causes of maternal mortality, it's either between postpartum hemorrhage or hypertensive disease of pregnancy. Interestingly, it appears from the data that we have that the urban areas seem to report more of the hypertensive disorders of pregnancy resulting in mortalities, whilst the rural or the areas in the periphery tend to report more of these issues to do with postpartum hemorrhage. There still needs to be some more research done to look into the causes, but it appears that it might have something to do with the fact that even in today's world, quite a number of women still deliver unattended by any trained medical professional. Either a family member or traditional birth attendants still help in conducting delivery. And we know that the moment you have a case of postpartum hemorrhage, it can be touch and go. The golden hour cannot be ignored. So these are challenges that we still face. And in fact, the good news is even from the preliminary data, like the Ellavi Uterine Balloon Tamponade device, it's perfectly situated to take the place of, rather do I say, troublesome condom tamponade that we tend to use. So far, I've been involved in some of the training sessions, and the good news is a lot of the respondents immediately, whether we're talking about the midwives or the doctors or anybody who is concerned, the moment they understand the basis of the Ellavi UBT, the reason for it, noting the fact that it is quite easy to deploy fast and then also quite cost effective, the interest immediately comes up. So we are really looking forward to far better results when this is spread throughout the country. The FDA has already approved it. I heard it's on the drug list of the Ghana Health Service. And the bottom line, I think, is that any measures that we put into place to arrest PPH would eventually affect the maternal mortality ratio. The last thing I'd like to mention, especially in our part, which I do discuss with clinicians, is the fact reducing maternal mortality ratio, etc. Forgetting that for each index of which would form that ratio is a human life. And the moment the mother is lost, in most of our cases, the children also have complications, whether in some cases they might not even be able to grow to their full potential. So we are looking forward to very good things with the deployment of the Ellavi UBT in Ghana. Thank you very much.
Okay, so thank you very much. Thanks for that kind introduction. Thank you for inviting me. Thanks to Sinapi for organizing this symposium today on such a really important topic. So I'm going to look at postpartum hemorrhage in general, put it in context, give an overall approach to managing it, and try and show how balloon tamponade fits into the overall approach of managing PPH. Well, I don't need to tell everyone that postpartum hemorrhage is common, probably the most common cause of maternal death worldwide, particularly in developing countries. In South Africa, I work for the Confidential Inquiry into Maternal Deaths, and my job has always been to look through every single woman who dies from hemorrhage in South Africa, and that's about 200 a year. And what is really sad is that over 80% were completely avoidable. And when you go through files of women who've died from hemorrhage, you can hardly look at some of them without really having tears in your eyes when you think that more than 80% could have survived. They needn't have died. This is, you maybe think I'm going back to do fourth year obstetric teaching, but I think it's good to say what is postpartum hemorrhage, and I'm going to come on to this a bit later, because we have a definition of postpartum hemorrhage as being blood loss more than 500, because we believe that after that, all the complications start to appear. And we say that PPH at or after cesarean section is 1,000 mils. And I think these are important definitions, and I'll come on to this later, is actually, do we pick them up? Do we always know when a woman's lost 500? Do we always know when she's lost a litre at caesarean section? And I'm going to cover this a bit later. The causes, again, I hardly need to tell this audience, but to stress that after vaginal delivery, we're looking at the tone of the uterus, trauma, tissue which is related to the placenta, the bleeding that happens after a placenta previa and an abruptio placenta, and then at caesarean section, it's similar to uterine atony, trauma, bleeding from the placental site, and all of these can lead to problems of coagulation, which some people will call the fourth T, or thrombin. Now I'm going to just share with you our most recent report of maternal deaths in South Africa. Because although there's 2 years have happened since then with the COVID pandemic, and I'll touch on that. So in this report, we had 544 deaths, and hemorrhage accounted for 15.7%. It was the third cause. And we were quite encouraged to see that we'd had a steady decrease in PPH since 2013, where we were very much alarmed about it. And a lot of interventions had been put in South Africa, both for PPH after vaginal delivery and after caesarean section. Limpopo, as was mentioned by the Honourable MEC, had almost the highest maternal mortality rate from hemorrhage, but it has actually come down. And so although it started from a high level, it was on the way down. Now in 2020 and 2021, during the COVID pandemic, deaths from COVID pneumonia became the most important. But actually we believe that deaths from hemorrhage started to increase slightly again. And we think that's because of the indirect effect of the pandemic on the health service. It really affected staffing. People were sick, people were deployed, there weren't beds in ICUs. It had a devastating effect on the functionality of the health system. And so we think we've had a slight increase in hemorrhage during the pandemic years. As I've mentioned before, very concerned about how many of these deaths are preventable. In terms of the causes of hemorrhage, I think the most common group are the PPH after vaginal delivery, which is probably where UBT fits in most, the atony, retained placenta and trauma. But it's of note to know that bleeding at or after caesarean section is a really close second grouping of hemorrhage deaths. And then we've got the APH deaths, which we're not really going to discuss today, and the ruptured uterus deaths, which obviously aren't ones where you're going to use balloon tamponade, but it's very, very important that they're considered as a differential sometimes in trying to find the cause of a postpartum hemorrhage, because sometimes the ruptured uterus manifests as a PPH. This is just to show you the trends which we were very happy about in our last report. And this is over 12 years. Deaths from postpartum hemorrhage were coming gradually down. And then these were the deaths from PPH after vaginal delivery, coming down, but still this is the biggest group. The deaths at caesarean section bleeding went up for a while, and we got very alarmed at this stage and introduced various safe caesarean delivery programs aimed at improving skills, and Limpopo has been very involved in this, alerted people to this problem, and thankfully in the last triennium these deaths from bleeding after Caesar came down, and these are the APH and ruptured uterus deaths, which had come down quite significantly too. Now, as I've said, I look through every single folder of a woman who dies from hemorrhage. And just to summarize, what were the main features in those who I allocated them as preventable? Well, the big thing, and this relates to what I was saying earlier about the definition being 500, the biggest problem almost was late detection. So I think when we're trying to reduce deaths from PPH, we've got to look at medications and technologies, but they're only so good if we actually recognize the problem. And if we recognize the problem too late, we're starting our management too late when the woman's got a coagulopathy. And unfortunately, all too often, a woman was diagnosed with a PPH only when there was a puddle of blood on the floor or her blood pressure dropped. And as we know, these are very late signs. And women who've lost 500 mils don't actually drop their blood pressure or have a tachycardia or have a puddle on the floor. And it's how we actually can pick them up at the correct time, so we intervene earlier. And I noticed that the professor from Kenya mentioned the emotive study, which is one that's trying to measure blood loss more accurately with a drape so that we pick it up earlier. The other reason I think for poor problem recognition is because inadequate monitoring, and we think we've done everything, the baby's out, that's it. But actually it's after the baby's out in the first half hour where she might bleed, and often there's inadequate monitoring, and that was probably made worse during the pandemic where there were shortages of staff. When the PPH is recognized, often a slow, rather sequential response. Let's try one thing, if it doesn't work, let's try another. And then I think this fourth one is very relevant to the use of uterine balloon tamponade. After the first response, which many people were doing, oxytocin infusion, uterine massage, a drip, it was if she carried on bleeding, people were a bit slow to do other measures. Some people were too frightened. They thought the only next thing they could do with a hysterectomy was actually compression sutures and balloon tamponade can be done by a medical officer, a clinical assistant in a district hospital who can't do a hysterectomy, but it can allow these women to survive. And the other big problem we noticed with referring unstable patients, very easy to think, well, I can't do anything more here, let me put her in the ambulance. And then she dies on the way. And again, as was mentioned, I think in some of the presentations, I think from Botswana and maybe Ghana, the balloon tamponade is useful in this scenario. So let me get back to detection. I've mentioned a bit about this. I mean, symptoms, the patient reports bleeding, we see bleeding, we have the reduction of blood pressure, the increase in heart rate. Most of these here are very, very late signs. We're not very good at quantifying it, and we need to do this better. Perhaps the earliest sign actually is a slight increase in heart rate. I mean, when the woman's lost a litre, the heart rate will go up. And in terms of the post, but we actually need to work out ways in which we can pick up PPH before the patient has symptoms. And I think this is a challenge I throw out to everyone. How can we pick up PPH earlier, given what we're currently doing? The approach to management, it's very good to have an accessible protocol or a poster on the wall. Management has almost got two channels, resuscitation, circulation, airway, breathing. And the reason to call for help with a PPH is always because you've got to have someone doing resus and someone doing stopping the bleeding. I think with any PPH, there's always a first response. And this doesn't, you don't have to know the cause for this. I think with any PPH after vaginal delivery, put up a drip, massage the uterus, make sure the bladder's empty, and give an oxytocin infusion or whatever is your protocol in your country. And then while this first response is happening, then you kind of can go further to look at the cause, which is the 3 T's. Do everything to stop the bleeding and do not leave the patient. This question of, okay, let's try this, I'll come back in half an hour, I'll try this and come back. No one should leave a patient who's bleeding until actually the bleeding has stopped. And this is our South African algorithm. And I'll only go through it a little bit. but it's what we find is quite useful. It's got a box, and this is just active management of the 3rd stage of labor, and that's really important. 10 units of oxytocin IM is what we do. This is diagnosis. This is our first response: call for help, massage, a drip, oxytocin infusion, monitor, and make sure the bladder's empty. And then the further things we do depend on the cause. So if the placenta is retained, we deliver it. If we think the placenta is incomplete, then that's usually theatre. And then this is now where we're getting more towards refractory PPH, where the bleeding carries on. You know, and if we think it's atony, we go down this channel, which is considering ergometrin or symptometrin if she's not hypertensive, and tranexamic acid, misoprostol. And what is changing, though, is I think this tranexamic acid, which we've had as a 2nd line, I think in our next protocol is going to come up to 1st line, because there's a lot of evidence to show that it is effective and it should be given early on in the PPH problem rather than late. So our next ones may move that there. And then I think it's when you've done all you can for uterine atony, and this is in a labour ward, you're pretty sure there's no trauma or retained products, is where balloon tamponade comes in. This box relates to suturing all signs of trauma. This box relates to the fact that very, very rarely there's uterine inversion, but I'm not going to go on about that in detail. Now here we've got refractory PPH, ongoing bleeding, and often for this, what is needed, if all else has been done, is explore in theatre for retained products or very high cervical vaginal tears. And again, balloon tamponade can be inserted here. Some people will do it in labour ward, and it can also be inserted in theatre. And then we're going now to last resort things, which is laparotomy. And these are the things that can be done there. And a lot depends on the skill of the person. And if one has to refer, you've got to do all that you can to make sure she gets to the next level of care alive. And again, balloon catheter tamponade, useful for referral, as could be the anti-shock garment. A little bit on resuscitation, which mustn't be forgotten. And this is mostly about circulation. Get the drips up quickly and start off resuscitating with crystalloids. And most district hospitals should have emergency blood, group specific. And in terms of coagulation disorders, what has really helped us in South Africa is the discovery of fresh dried plasma. If you're in a center with a blood bank, you can get fresh frozen plasma, but most district hospitals aren't anywhere near a blood bank. So this powdered plasma, which you reconstitute with water, has made a huge difference to us in our district hospitals in South Africa. I've talked a bit about uterine atony when I described the algorithm, so I'm not going to go through it in great detail, but this is the kind of sequential approach. We tend to start with oxytocin. Our second line is symptometrin or ergometrin and tranexamic acid. We do sometimes give misoprostol, although it is known to be less effective than other methods. And we consider aortic compression, look for other causes, and this is also where uterine balloon tamponade, ongoing bleeding, we go to theatre to explore further. And important not to delay between the steps. I'm not going to mention this much, except really to say that different countries may have different availability of drugs. In South Africa, we've got oxytocin, we have misoprostol, we have symptometrin, we don't anymore have ergometrin. We don't have carbetocin in the public sector. I know many countries, this is a long-acting oxytocin, Many countries do have heat-stable carbetocin as a result of the Champion trial. And this is a really good preparation because it doesn't need a fridge. And one of the problems of oxytocin and sintometrin is they need a fridge. We in South Africa don't have PGF2 alpha or carboprost, so that's not part of our protocol. And just what I've mentioned before about the tranexamic acid, in a way it's the new kid on the block, but there is evidence to show that it's a valuable addition to managing PPH, whatever the cause. This is just a picture of bimanual compression. I think very much something that should be done while waiting for senior help. Really by compressing the uterus, you reduce bleeding until something definitive happens. This is a picture of aortic compression, where you put your fist on the woman's abdomen, just lateral to the aorta before it bifurcates. And these are all things that you do, because the more you can reduce the blood loss and prevent coagulopathy, the better or easier your management is going to be. A balloon tamponade, mostly I'm not going to talk much about this except where it fits in, and everyone has talked already about the homemade systems. I used to try these. I always I think I wasn't a very good plumber. I always got leaks in my systems. I couldn't quite stop fluid pouring out. So I was very, very encouraged when the Ellavi balloon came along, because it was cheaper and it had some principles of the glove balloon, and it was already assembled, so you didn't have to worry about getting tight fit and leak-proof symptoms. But retained placenta cannot be forgotten as a major cause of PPH. These patients become shocked very quickly, and we have a policy in South Africa that they should be removed. Wherever they occur, they should be removed. There was a time when our midwife units used to refer women with retained placenta to the hospitals, but in so doing, the women bled enormously during the transfer. So now we've trained our midwives to actually do manual removals. It's not widespread, but we feel it should be a midwifery skill, and anyone working in a labour ward should be able to do a manual removal. If it's tissue remaining, this usually requires a theatre, can be done manually, but for retained placenta, again, I think there's a place for uterine balloon tamponade afterwards, but occasionally the placenta is retained because it's slightly adherent, and it's a bit difficult removing it, and it leaves a placental site which is bleeding, and a uterine balloon tamponade is excellent for placental site bleeding. Genital tract trauma, we always think, oh, that's easy, suture the episiostomy. I think it can be really difficult when there are deep vaginal tears or cervical tears. And my worst nightmare is often where there's extensive vaginal lacerations, where you see about 20 little lacerations, and it takes a long time to suture. And here again, tranexamic acid can be of value, and some kind of, I've done a lot of vaginal packing. I've never used balloon tamponade for the vagina, but some people do say that you can use it for extensive vaginal lacerations. If you suspect uterine rupture, that has to go to theatre. There's no way that can be treated conservatively. And what is done depends on the level of care, whether it's a repair, subtotal, and what we've advised in some of our district hospitals, if they identify uterine rupture, they should open the patient, and if they can't do a hysterectomy, and it's not amenable to repair, we use this procedure, which was developed, I think, in Zambia, of tying a catheter tightly around the lower part of the uterus, like one might do for a myomectomy, and it constricts the uterine arteries while you refer. after vaginal delivery, if all these things don't work, then your next approach is to do a laparotomy. And before I go on to what you might do at laparotomy, I'm going to now slightly digress to bleeding after Caesar, because what you do for bleeding at Caesar is the same as what you might do at a laparotomy for PPH after vaginal delivery. I mentioned in South Africa that bleeding after Caesar or at Caesar is almost equal to PPH after vaginal delivery as a major cause of death from hemorrhage. And it's really important that unnecessary Caesars are not performed. It's not a simple operation, cesarean section. That patients are preoperatively assessed. What's her HB? What's the bleeding risk? Where's the placenta? How many Caesars has she had, etc.? Is she at the right level of care? A slow Caesar, there's often a competition to do a cesarean section in less than 10 minutes, and there's no bravado in that. And a careful Caesar, where hemostasis is secured, and to be aware that sometimes the blood comes underneath the drapes, and you need to check that that's not happening while you're doing your operation. Recognition, again, quite difficult. Suction bottles often take liquor, and it's not always easy to know how much blood she's lost, and one does rely a lot on vital signs and stopping the bleeding. This is a uterine compression suture, and I actually think that if you have bleeding from an atonic uterus at cesarean section, this is the best modality of treatment. If you are doing a laparotomy for someone where you can't control the bleeding after vaginal delivery, then you do something called the Hayman suture, because you won't have the scar in the uterus, and you certainly don't want to cut open the uterus. So then it's just 2 braces. But compression sutures are very important for atony in someone who can't do a PPH, can't do a hysterectomy. Uterine artery ligations, again, more useful probably for bleeding at Caesar, where it might help with lateral uterine tears. This is our algorithm for bleeding at Caesar. At cesarean section, we tend to, because we give the oxytocin for prevention intravenously, we give lower doses, because if you give a high dose quickly, IV, it tends to drop the blood pressure. But the algorithm is rather similar for vaginal delivery, except we tend to give the tranexamic acid a bit sooner. And then again, your management at cesarean section of extensive bleeding will be depending on what you think the cause is. So if it's an atonic uterus, you'll give all the medications. And then I think my first preference is a uterine compression suture. And usually that works. You can then do what's called uterine sandwich technique, which is you then put in a balloon after you put in this. And you've got compression from outside and tamponade from inside. Trauma at Caesar needs to be repaired carefully. If you think the bleeding's all coming from the placental site, particularly if it's been a placenta previa, then again, there's a big role for balloon tamponade. It can be extremely valuable. And that's the first time I ever actually used it, was for a placental site bleeding after a placenta previa. Now, this is a color-coded observation chart, and I'm putting this here to emphasize the importance of the observations after delivery and after cesarean section. If we want to pick up PPH early, we've got to do these well in labor ward or in the recovery of the theatre. And often, if staff are taken away from an area, they're taken away from a monitoring area. And actually monitoring and picking things up early is so important. It's also important to be aware sometimes the bleeding is concealed, such as a paravaginal hematoma or intraperitoneal after a Caesar. And I think there should almost, we use the surgical safety checklist, but I think there almost needs to be a little check before the woman goes to the postnatal ward. Once a woman's in a postnatal ward, the chance of picking up a PPH, in my experience, is very low. So if we can check in labor ward before she goes, she hasn't got a pulse above 100. In recovery, and we also check she's stable, we might pick up more PPHs. And this is where I'll be very interested in Prof Theron's comments. This is quite often, unfortunately, we do find the woman bleeding in the postnatal ward. So this is an algorithm for what you do when you find her bleeding in the postnatal ward. And we tend to do our first line, give oxytocin tranexamic acid, and then think, you know, do we think this is an atonic uterus? She had a prolonged labor, or the uterus actually is well contracted. So do we think it's trauma? And it's really important not to delay reopening these patients, because there can be a bleeding vessel at the angle or something that was missed. So I tend to not advise my doctors to immediately put in a balloon here. I'm a bit worried about a balloon in case there could be trauma. So I'm more inclined to think of the balloon after you've opened up the patient, and you've done a compression suture, and then do it. And I've been looking for literature on the use of balloons for bleeding after seizure, and there isn't much as I can see. I think it's very useful if you think it's placental site bleeding. And as I say, I think it's very useful if combined with a compression suture. The one time I think you might put it in here is when the doctor, for some reason, the doctors in the district hospital say, we can't do a laparotomy, no one can do a GA, we've not got a theatre. Then I think probably to put it in before you transfer the patient may be useful. We see far too many patients, though, being transferred when they should have actually been operated on. And now I'm coming to my last little bit, which is about the transfer of unstable patients. I think it's a real dilemma sometimes in a district hospital, and I see this when I look through maternal case folders, the dilemma. The doctor feels unconfident, they don't know quite what to do. So should they put her in an ambulance, or should they treat? I think balloon tamponade, uterine compression sutures have really helped people have the confidence to actually treat. However, if they've done all they can and they feel they have to transfer, then the importance of measures during transfer to make sure she arrives alive is important. And these measures include tamponade, the uterine tourniquet technique I mentioned, and the non-pneumatic anti-shock garment, which I'll show you a picture of. So this is just, I think most of us in sub-Saharan Africa have maternity care systems organized around level of care. We don't have all our women delivering in hospitals, and we do this for human resources reasons. So we do have women who bleed at lower levels of care, and the staff do all they can, but there is going to be a need for urgent referral. And we have found in South Africa that problems of referral occurred in at least a third of our patients, and in about half of the women being referred from district hospitals. And this is just perhaps a little bit busy, but I looked in detail at 120 women who had been referred after they bled. And of those 120 women, a fifth of them died in the facility awaiting the ambulance to come. Then a further 14.2% died on the way in the ambulance, and only 2/3 got to the next level of care. And of those, half of them arrived an absolute extremist and died within 4 hours. And I think what this is saying to me and said to us in South Africa, we have to empower the district hospital to do more so that it does more for women before they refer these women, because then they're not going to arrive alive at the regional hospital. And that's where more conservative, all the things I've mentioned so far, and including the UBT, the compression sutures, the Foley's catheter. My last slide is just to say hemorrhage is frightening. It still frightens me when I'm in a labor ward situation and a woman is bleeding heavily. It's a frightening condition. And if we can prevent it, all the better. We can prevent the sequelae of PPH by looking at anemia. We're not often good, we often rather neglect this in antenatal care, but making sure that we supplement women and we look for causes and treat anemia. To try and be prepared as far as possible to say at what level of care women should deliver. To have our supplies all available, PPH boxes where you've got everything in one place, never run out of essential medicines, etc., emergency blood. So this is really more administrative. Preventing prolonged labor. We know prolonged labor is a big underlying factor for PPH. Active management of the third stage of labor reduces PPH by 66%. And then the routine monitoring to pick it up early. And interesting, when I teach midwives about PPH, they'll sometimes will say to me, well, it's mostly for the doctors to manage. And I said, well, actually, what the midwife does is, firstly, it's the major thing in preventing PPH. Every single thing you do as a midwife in labor ward can prevent PPH. And actually, there is an awful lot now I know that a midwife can do in terms of treatment of a PPH. So I'm going to stop there and thank you for your attention.
I have no conflict of interest. I did not receive any remuneration from Sinapi or hold any appointments in the company. Traveling and accommodation costs for this symposium in Polokwane was funded by the Johnson & Johnson Global Fund. Next slide. Pliny the Elder, who was a Roman philosopher and naturalist, exclaimed, out of Africa, always something new. And that was shortly AD. Now this, the Ellavi Uterine Balloon is out of Africa and something new. Next slide. We became aware of the use of uterine balloon tamponade in 2001 when
Apologies, Prof.
a case of 6 women in the International Journal of Obstetrics and Gynecology, where the Bacter uterine balloon was actually used. 5 of the women had either low-lying placentas or placenta previous, and the 6 women actually had a cervical pregnancy. Next slide. Now, the use of uterine balloon tamponade,
can I please have the attention of the Limpopo people?
Quickly, and when we did a literature overview, which was shared by the editor-in-chief, was Sebastian Suarez from the Massachusetts General Hospital, we found 3,653 papers, of which 644 met the initial screening criteria, and then 91 the more strict inclusion criteria. So the 91 studies comprised about 4,700 patients. Of those, as for Fawcus as mentioned, 69 were case series. There were 15 non-randomized controlled trials, and there were 6 randomized controlled trials, as well as 1 cluster randomized controlled trial. The overall success rate was 86% with narrow confidence margins. Next slide. Understandably, soon after the uterine balloon tamponade case series was published, the combined use of uterine balloon tamponade together with compression sutures were published, and it was regarded as a very effective method of managing a refractory postpartum hemorrhage. However, shortly after that publication, we became aware of the fact that necrosis was possible following the insertion of compression sutures, and the risk for this actually increased if you combine the two, compression sutures with a uterine balloon tamponade. just move on to the next slide. Yeah, that's the slide where we are. And then quite a number of publications came out explaining these, the fact that uterine necrosis can happen. And the conclusion actually is if you're going to use uterine balloon tamponade following compression sutures, you must be able to control the pressure inside the uterus. You must know how much pressure you have in the uterus. And if you use a closed system, you just put in 500 mils of fluid, you have no idea how much pressure you have. The picture you see there is a patient that had a uterine balloon inserted together with compression sutures. A rush catheter was used, which is actually used for bleeding in the bladder. And 6 weeks postpartum, she was readmitted with an acute abdomen. And on that laparotomy, she had necrosis of the fundus of the uterus and required a hysterectomy. Next slide. Now, Fawcus alluded to this very important point. The problem of the referral of patients, which I think is very relevant in your province, in the Limpopo province, because of it's a big province with huge distances. And she pointed out that in that confidential inquiry mentioned there, 20% of the patients that died due to hemorrhage that was referred, it was 128 patients, 20% of those died while waiting for the ambulance, and a further 14% in transit. So we definitely need a method that could be used at primary care level in the MOUs, as well as district hospitals that require patients to be referred, to make the referral process safer for the patient. Next slide. So our problem was the commercial devices was very expensive. WHO suggested using a condom catheter with a Fawcus catheter. You can see a 20 cc syringe there connected to the Fawcus catheter, but there's a little device inside the Fawcus catheter that actually helps the syringe to fit into the Fawcus catheter. Otherwise, you're really going to struggle to get the fluid into the condom. The 50 cc syringe actually works better. At that time, I thought a surgical glove may work better than a condom. Next slide. And if you tie the top end of the surgical glove, a sterile glove, and you snip the middle finger, and then you can use the 2 other fingers to tie it over a synaptic catheter, which can either be a nasogastric tube or a suction catheter that's more firm than a Fawcus catheter. And then you fill it up with a given set from a liter of IV fluid, so it fills up quite rapidly. So that was described in 2008 in the Intrapartum Care Manual of the Perinatal Infection Program. And in 2010, NCCMD brought out a monograph on the management of postpartum hemorrhage, and I was responsible for chapter 6, which was the surgical management of postpartum hemorrhage that included the use of uterine balloon tamponade, and we had the opportunity to explain the use of the glove balloon further. Next slide. The glove balloon had 2 unique features. The first one, it allowed intrauterine pressure control by adjusting the height of the liter of intravenous fluid above the patient, taking into account that the specific gravity of mercury is 13 times that of water. You know, if you want 100 millimeters mercury pressure inside the uterus, you just put the drip stand 1.3 meters above the patient. You know exactly what pressure you have inside the uterus. However, the caveat is that the balloon must be able to be inflated without taking up expansion pressure, because if it takes up expansion pressure, your equation doesn't work. So we did an experiment at Sinapi where we used a glove and we used the Ellavi Uterine Balloon, we used a condom, and you could actually see that both the glove as well as the Ellavi don't take up expansion pressure up till 750 milliliters of fluid. The second big advantage is it's a free flow open system. In other words, when the uterus starts contracting, it can push fluid back into the IV fluid bag or the supply bag. And that's our aim with the management of postpartum hemorrhage, is get due to atonic uterus, is to get the uterus to contract. That's why we rub it up. That's why we give oxytocin drugs. And the free flow system allows that to happen. Next slide, please. So I had a few ideas on the shelf for retirement, and I had to take retirement at the end of 2015. The dean said, "You're now 65, you now have to go." So this was one. I knew there was a need for a commercial device with the qualities of the glove balloon. And I knew about Sinapi because they manufacture the neonatal feeding cup that the MSc also alluded to, that is used widely in our country. So I approached them and I said, can you design and manufacture a uterine balloon with the following features? It must be a single unit, it must have a supply bag, it must have a valve in the tubing, it must have a cylindrical shaped balloon that can fill up to 750 mils without taking up expansion pressure. Next slide. This then became a combined effort from the University of Stellenbosch, which I represented, the South African Medical Research Council and the Department of Science and Technology that provided funding, Sinapi that became the product developer, and PPH, which is a non-for-profit company based in Seattle that aims towards developing new medical devices that can be made available cheaply to low and middle income countries. So they were sort of a partner along the road together with us. But the funding was a grant from the Medical Research Council and the Department of Science and Technology. Next slide, please. That's the end product that you all know, the supply bag, tubing, and then the T-valve and the balloon. The important point here is that the piece of tubing distal to the valve was initial of the same tensile strength as the rest of the tubing. It was just ordinary tubing. And with our initial insertions, the balloon tended, the tubing tended to curl around. And then we met with Sinapi, and the strength of that piece of the tubing distal to the T-valve, the core hardness was increased by 40%. And now it inserts easily, it doesn't curl around, and it goes right to the tip of the balloon, so that if that piece of the tubing is against the fundus, you know your balloon is also against the fundus. Next slide. We had to consider the need for a drainage port, as our colleague has alluded to just before this talk. And we thought about it, and I think the following points are important. Usually the drainage ports have got a diameter of about 2 millimeters. They are easily blocked or clotted, blood clots, and it's often on the tip of a small bit of tubing that gets kinked. And we know the placental implantation site only comprises 20% of the inside surface of the uterus, and it could be anywhere in the upper segment. And if your port isn't close to the implantation site, it probably will not drain. And what we learned from practice with the glove balloon as well as with the Ellavi, if there's ongoing bleeding, it is excessive, it is obvious, it exceeds the capacity of a small port, it escapes past the balloon through the vagina, and you can easily pick it up that the balloon did not succeed in stopping the bleeding. And what we know is very, very important. The one person I met yesterday evening, where is she? Not inside. such the Sinapi representative in Limpopo, and she's an intensive care registered nurse, and we discussed this about staying ahead of your problem. If a patient is quite ill, and if a patient is bleeding, you must stay ahead of the bleeding. If you fall behind, you lose the risk of losing your patient. And the advantage of the Ellavi is the balloon fills up in 45 seconds with 750 mils. And you can make an immediate assessment. Did it stop the bleeding, yes or no? And that's very, very valuable. If the patient is bleeding profusely, you insert your balloon, inflate the balloon. 45 seconds later, you can assess whether the bleeding is reduced. If the bleeding is not reduced, and if the bleeding continues profusely, this step in the management bundle has failed, and you have to proceed to the next step in your management bundle. Often the bleeding reduces, but it's not completely resolved. And in that case, you can wait a little bit longer. You can wait 15 minutes and say, okay, let's see what happens over the next 15 minutes. And if there's still ongoing bleeding after 15 minutes, then you know your method has failed. So it's very important. The uterine balloon tamponade is one step in your management bundle, as for Fawcus has clearly demonstrated to us. And if it doesn't work, you just continue with the next step in the management bundle. And this is a problem with the two randomized controlled trials conducted with condoms in Central and Northern Africa, which showed it didn't work because the settings were settings where there wasn't the possibility of next steps in the management, and where there were often delays, often there were no blood available. And the conclusion of those studies that we can make is that if you do study on postpartum hemorrhage, you must do it in a setting where you can provide the full package to the patient. If one step fails, you must be able to continue with the next step. Let's go just the next slide, please. We're quite further on now. Let's just go to the next slide. Next slide. Next slide. Okay. How do you control the intrauterine pressure? The pressure inside the balloon by the height of the supply bag above the patient, and for that reason there's black rings on the tubing. The ring closest to the bag, if it's that height, is for gives 60 millimeters mercury pressure. And the next ring 80, the next 100, and the one closest to the balloon is for a systolic blood pressure of 120 millimeters mercury. And that's the range with which we work, because that's the length of the tubing. If the blood pressure is lower than that, you keep it at 60 millimeters at the first black ring closest to the bag. If the blood pressure is higher than 120, you keep it at the black ring closest to the balloon. So we work with that range, but you will always know what pressure you have inside the uterus. And at the FIGO conference in 2000 and when it was 2018 in Rio, the person that has done a lot of work on uterine balloon tamponade is Sir Sabaratnam Arukumaran, who was the president of the Royal College and the president of FIGO. And we had a workshop at that conference, and I discussed it with him. I said, why does uterine balloon tamponade work? And he says the only biological plausible answer is the amount of pressure that you apply on the bleeding site, the implantation site of the placenta, must more or less equate systolic blood pressure, because it's arterial bleeding from the placenta implantation site that we want to tamponade. Next slide. Now, one side effect, which is not a big problem, and it's seldom experienced, but it happens, that we learn from practice, is abdominal discomfort once the balloon has been inflated, the uterine balloon. Well, how do you manage that? you lower your supply bag halfway, whatever height it is, gently rub up the uterus, you'll see fluid flowing back from the uterine balloon into the supply bag, and the discomfort is relieved, and then you put the bag back at the original height. And that's quite easy to manage abdominal discomfort. That also facilitates contraction and retraction of the uterus. Next slide. Now, one of the problems with all uterine balloons, irrespective of which one, is that it's being expelled. And that occurs where the uterus contracts and retracts, what you want to happen. And how do you manage that? If the balloon, whichever one you're using, have been expelled and there's no further excessive bleeding, the problem has been solved and there's no need for a reinsertion. If once the balloon is expelled, there's ongoing excessive bleeding, uterine balloon tamponade has failed, and you need to proceed with the next step in your management plan. Don't delay, don't procrastinate. Next slide. Now, what devices are available? This is just a little bit of a more complete list that Fawcus showed. Fixed volume devices, the condom, and there's one that's commercially packed, contains a condom, a catheter, 50 cc syringe called the ECM UBT kit, the Buckley, and there's a new version of the Buckley 1. Then there's the Rush balloon, the EP system, and the BT catheter. There's quite a number of fixed volume devices. You put in 500 mils and you close it. And then the free flow devices is the glove balloon, the Ellavi, and then there's the Szynkowski balloon. The Szynkowski balloon only uses pressure to inflate the uterus, and they actually use very low pressure, 50 cc's. It's not generally available. It's not available in Russia. The only two devices that actually make use of intrauterine pressure control, according to the systolic blood pressure, is the Ellavi and the makeshift glove balloon. Next slide. Now, how do you scientifically evaluate a new device? That was the problem I was confronted with. Now, with the COVID pandemic, we know a lot about this. You first, with a drug or a vaccine, you do your animal studies. If half of the animal dies, you probably need to reconsider your product. And once you've done your animal studies, you proceed to phase 1 studies on healthy individuals. And if then the next step will be a case series on patients with the problem. And then you proceed to phase 3 studies, which will be your randomized controlled trials. And then even subsequently that post-marketing surveillance need to be done to check whether rare side effects may occur. And that you all know that is how we approach the COVID vaccines. But you can imagine with the case, with the device, you can't do animal studies, you can't do studies on healthy volunteers. So you start with case series. And once you've done your case series, you can proceed to a randomized controlled trial and then post-marketing surveillance. Next slide. So I had to do the case series. And I thought it's important to do the case series at the 3 levels of healthcare that we generally have in South Africa. At specialist level, which would be either an academic or a central hospital, at a medical officer level, which would be regional hospitals or district hospitals, and then at primary care level, which would be the MOUs. So case series was planned for these 3 settings, and we also planned each person that did the insertion, a structured interview was conducted with that person. And this studies was done for feasibility. Is it possible to do it? And the studies were done by intention to treat. Next slide. I'm just briefly going to explain the 3 studies to you. The specialist study was done at Tygerberg Hospital with the surrounding 3 district hospitals. in 2016 and 17. During the time we did the study, there were 29,000 deliveries in that setting, and we included 20 cases, but in one case, the bag was open and not used. Next slide. It stopped the bleeding in 15. It was unsuccessful in four of the patients. 7 of the patients were delivered by cesarean section. So we started gaining experience using uterine balloon tamponade in patients delivered by cesarean sections. Next slide. This was published by that newspaper in the International Journal of Gynecology and Obstetrics in 2018. Next slide. The medical officer study was conducted in St. Elizabeth's Hospital, which is a regional hospital in Lusikisiki in the rural Eastern Cape with no specialist cover. It's a busy hospital. I think the setting may be much similar to some of the hospital in Limpopo. It was done in 2018 and 2019. The annual number of deliveries in that hospital is about 5,100 patients that's delivered, and we included 10 cases, and in 9 cases the bleeding were controlled. All patients were referred to Nelson Mandela Academic Hospital in Limpopo after insertion. Next slide, please. The study was published in South African Journal of Family Practice. Next slide. And then the midwife study was conducted in 6 midwife obstetrics units in Cape Town, in Metro East, the eastern part of Cape Town, in 2018 and 2019. The annual number of deliveries in these 6 MOUs is about 9,700 deliveries. We included 12 cases, in 2 cases bags open but not used. Next slide. So in the 10 cases that had insertions, 8 were done by midwives, and all 8 were successful. 2 were done by medical officers, which usually were working in the casualty section of the primary care facility, and 1 was successful. Next slide, please. I just want to mention a clinical case. This was the very first patient included in the midwife case series. The midwives had their workshop about 10 days prior to this incident. A patient that had received no antenatal care was admitted. She was having a full para-3 from a neighboring country, and she was in advanced labor and obviously with the term pregnancy. The admission HB was 7.8. This sounds familiar. And she delivered shortly after her arrival, only to be diagnosed with undiagnosed twins. The midwife kept her cool, delivered the second baby and the placenta, and this was followed by torrential bleeding on an HB of 7.8. The blood pressure dropped to 50/30. Immediate emergency measures were implemented. A second IV line was inserted, but the bleeding continued. The midwife inserted the Ellavi Uterine Balloon, and the bleeding stopped on inflation. The patient was transferred to the next level of care, where she received 3 units of blood. That was all that was required, and was discharged in good health. The waiting time for the ambulance in this case was 2 hours. What would have happened to this patient? And this, again, I think you can all feel this situation often happens in the setting you work in. Next slide. So the midwife study was published in the African Journal of Midwifery. Next slide. So the conclusion of the 3 case series was that it's feasible. People get it right. They insert the uterine balloon successfully. They prefer a pre-packed single unit that's a sterile device. The filling of the bag and the controlling of the pressure inside the bag was done correctly. The overall success rate was 85%, and this included 39 insertions. Of those 39 patients, 13 patients were delivered by cesarean sections, no complications, occurred, all patients, including the referred cases, had a good outcome. So this was the final conclusion. Next slide. Now, the next study that actually included Ellavi was conducted at Harvard University by Elizabeth Maxwell. This was her PhD study. So they developed a simulation model and then they assessed different types of balloons. And the people that were trained in a workshop were medical students, senior medical students. Next slide, please. And the result of their study showed, comparing 5 different devices on a simulation model, that the Ellavi was rated the simplest, easiest, and fastest device overall. Both the Ellavi and the ESM UBT, which is actually a condom catheter, were low-cost alternatives to expensive commercial devices and not inferior regarding the ease of use and may be superior to the battery. I quote what was written in the thesis. The app is fast to use but confusing with a high error rate. It's also extremely expensive. The battery not as highly rated as expected, as it is regarded internationally as the gold standard. So this is the conclusion of this PhD thesis. Next slide. Now this is the management bundle for patients that have a normal delivery that Sue also showed you. And I just want to show you the part of the uterine balloon. Next slide. So usually if you're in a hospital and there's a postpartum hemorrhage, the patient is examined in theatre to explore for lacerations and the retained products. Once that has been excluded and the bleeding is ongoing, a uterine balloon is inserted. If the bleeding is ongoing after the uterine balloon is inserted in theatre, the patient must have a laparotomy without a delay. But the patient must be draped in the modified Lloyd-Davis position. This is like being in a thotomy, but just lowering the legs by about 45 degrees. So there's place for the surgeon to stand. Usually the theatre nurse now stands between the legs of the patients. Once the abdomen is open, aortic compression can temporize the bleeding. Then the surgeon must compress the uterus with both hands and observe what he does to the bleeding from the vagina, because the patient is draped correctly for that. If it reduces the bleeding, you know compression sutures will also reduce the bleeding. So then compression sutures can be inserted. If the bleeding stops, problem solved, abdomen closed. If the bleeding continues, then you can use a combined uterine balloon tamponade by inserting a uterine balloon from below into the uterus. If the bleeding stops, problem solved. If the bleeding continues, you're in theatre, you can continue a stepwise devascularization or a hysterectomy. Next slide. This is the bundle for cesarean sections, and we're just going to focus on that one block. Next slide. So what do you do if you're in theatre, you did a cesarean section, you deliver the baby, you deliver the placenta, and the patient is bleeding. Some people will insert mattress sutures into the placenta implantation site. It mostly doesn't work, but then the patient must be re-draped in the modified Lloyd-Davis position. This only takes 2 minutes or less. Theatre system not usually impressed with the suggestion, but you as a surgeon must know whatever you do in the abdomen, what effect it has on the bleeding, because you can observe that directly. Gain compression by manually, bleeding reduced, compression sutures, problem solved. There's no further need for further management. If the bleeding continues, then a uterine balloon can be inserted from below and inflated, and in most cases, the problem will be solved. If not, then you continue with the next 2 steps. So there's no delay in the process. The worst thing for a surgeon is to do something in the abdomen, and when the patient is woken up and undraped, to realize that bleeding is ongoing. You lose a lot of blood, you lose a lot of valuable time. Next slide. Now, I read this case report last year, published as a victory. How B-lean sutures and bilateral iliac artery, internal iliac artery ligation saved the uterus of a young woman with severe postpartum hemorrhage. A clotting defect was present at the time of internal iliac artery ligation. However, uterine balloon tamponade could have saved this dangerous procedure. It should have been attempted together with compressing sutures, which is much less invasive. So I wasn't impressed with this victory that was published, because I think a less invasive procedure, and our colleague from Kenya did actually tell us, no, it was from Botswana, that they are doing much less hysterectomies, much less devascularization now that they're using uterine balloon tamponade. Next slide. There is a workshop online that you can access by going to the Better Care website. You go to learning programs. In the top ruler, you go click on women's health, you click on interpartum care, on read free, on learning station, and then you go to skills unit 5 with unit 5, and there is all described. There's also, you can scroll down for a DVD that demonstrates this. Next slide. What studies are planned? There's an ongoing study conducted by Professor Justus Hofmeyr with the Ellavi uterine balloon as compared to the suction device in South Africa, and I believe also possibly in Botswana. And then WHO will be conducting the refractory hemorrhage devices trial, the RED trial. Recruitment will start in the 25th of July. We are most excited. So WHO decided to do a proper, well-designed, appropriately powered with enough patients to finally answer this question. And they will be comparing the Ellavi with the suction device and the standard of care in Vietnam. So they're doing it in 2 large hospitals in Vietnam where they conduct, believe it or not, about 70,000 deliveries annually in each of these hospitals. They've got like 20 doctors on the labor ward for 24 hours a day. It's just unimaginable. So we're really looking forward to the results of this trial. Next slide. So just about Sinapi, the Ellavi actually was a finalist in a competition called the Grand Challenges Canada. And the prize money actually was used to actually construct the production plant at Sinapi in Stellenbosch, and they now can supply enough balloons on demand. It's a CE regulated device, and the in-country registrations are increasing rapidly. Next slide.
Candace is the national sales coordinator for Sinapi, and then Miahawa is the Limpopo sales coordinator for Sinapi. So they will briefly show us what we've been talking about the whole time. Thank you.
Thank you, Dr. Mahmoud. Good afternoon. Welcome to all. Good afternoon to all our participants, all the countries as well, everyone from Limpopo, everyone from South Africa, warm welcome to all of you. Thank you so much for joining us. Thank you for still being with us. We are drawing towards the end of the session. So basically, I would just like to give you a small background on Sinapi, who we are, where we're from, and then just to show you exactly how the uterine balloon tamponade, for those who haven't seen it yet or haven't used it yet, just to show you what it looks like and how they insert, and also quite a few of the Limpopo districts have received training packages We also included the uterus model, and I'd like to show you what that uterus model looks like. So Sinapi Biomedical has been around for quite some time. So between 17 and 18 years, it's got various medical devices that are in facilities. We also export our devices to about 50 different countries. We've got our chest tray, the Sinapi chest tray, we've got a urine meter, we've got the Sinapi feeding cup, the Ellavi UBT, we've got various enteral feeding bottles, and a host of other medical devices, which are all locally manufactured in Cape Town, Stellenbosch. So we are homegrown for our own. So I will let me just show you quickly. So for those that haven't seen the Ellavi UBT, this is what it looks like. It comes sterile wrapped and sealed. Open it quickly. So for this demonstration, I'll be using the Ellavi UBT. I've got a drip stand with me. I've got some sterile water, which I've just added some coloring to make it blue, just for visual purposes. And we've got our uterus model. Our uterus model looks the following. So on the inside, we do train other health professionals. Obviously you're opening the vagina, and once you go in, you'll find the opening of the cervix, which is similar to here, just as your fingers go in. When your hand proceeds further, you'll feel the upper segment, which is a whole lot bigger than the rest of the uterus. So once you reach that part, that's one of the indications to how to insert. So when you open the Ellavi UBT, there are two components. So if we look at the makeshift devices, and we had so much fun this week explaining this, that in a case of PPH and I do apologize for saying, but the chaos that goes with it, we are all panicking, and for women's life that is at risk here. So then people need to go and have a little bit to go and find the various bits and pieces and consumables to make the makeshift device, whether it's a blood balloon or kind of catheter. You need to go and find them, you need to find a Foley catheter, you need to find everything that you need to assemble the makeshift UBT. When you open the Ellavi UBT, you find everything you need in one package. You'll find your supply bag. Your supply bag comes with the fill line, and then it also shows you the measurements between 250 and 1,000 more. So it will show you your measurements. And the second component would be the tubing, including the balloon. So at the one end of the tubing, you will find the screw cap. As Prof explained earlier on, the screw cap comes with a spike. So if you're in a position and it's easier for you to spike the vacuum, you're welcome to do so. We provide the spike for you. However, I want to just screw the cap onto the supply bag. Then you've got your tubing, you've got the T-valve, which is your tap, and then you've got your balloon. What I would like you to notice is that on this tubing, we've got two different types of tubing. You'll find that the tubing closer to the cap is a bit more softer, and you'll find that the tubing closer to the balloon is a bit more rigid. And you've done this specifically so that it helps you with inserting the balloon. Because if you just imagine it as one type of tubing, it will be very soft and very difficult to insert. Therefore, this tubing is a bit more rigid and helps when you need to insert. Okay, so when you are going to pour the saline or the sterile water into the supply bag, Once you've got your water in at this point, rather sooner than later, ensure that your tap is closed. If your tap is not closed and connect the connector to the bag, you might have the infected balloon, which you don't want. So we make sure that the tap is closed. If they will start closing the supply bag, what we want to do is to make sure that our drip stand is at its highest level. Because we want to start, we want to, number one, have rapid filling into the balloon, and we want to apply the maximum pressure at the point of the chicken. So our supply bag goes up. Okay. Once your supply bag is up, you get to your patient, which is our uterus model here. And I'm going to start inserting. Before I insert, and what we like to make everyone aware, especially with say our colleagues, is the way we place it. Because we can also find that sometimes the balloon can swell because it hasn't been placed correctly. So you'll take the balloon into the palm of your hand. I like to grab it into my fingers while I'm there in the palm of my hand, and I secure it with my thumb. Once the balloon is secured in my hand, I'll proceed to insert. I'm going through the vagina, and I'm going through the opening of the cervix. My fingers find the upper segment immediately. Once my fingers find the upper segment, I do not need to continue with my hand. I do not push my hand any further. I can stay that there. Okay. At this point, I'm going to start with my free hand on the outside. I'm going to feed the balloon further. Okay, the material doesn't make the paper, but you like to feed it with your free hand. Once you're feeding the balloon and you reach the distance, you reach the fundus, you do not need to continue. Once the balloon has reached the fundus, you can now play. Here you would not remove your hand that's inside. That hand needs to secure the tubing to avoid it from coming out. So you keep your fingers between the opening of the cervix, holding on to the tubing, and with your free hand on the outside, you will open the tap. Your balloon should fill within 45 seconds. We can have a look at the bag. All while the one hand remains. Okay, I'm also going to just remind you that how you place your drip stand, the quicker it will fall up. If you don't place your drip stand to the highest point, which is maybe about 1.5 meters, you will have a slower filling. So always try and get that drip stand, get that supply bag to 1.5, 1.6 to ensure that it's filling. At this point, while it's filling, you can also with your finger that's being at the opening of the cervix, you can feel the balloon filling up. You can feel that it's getting harder. You can feel the pressure increasing. And this is something that we've touched during the roadshow as well, is that sometimes we have different uteruses. Our uteruses come in different shapes and sizes. And at some point, you might need to add some more water, or you might not need all the water. If you've got a smaller uterus, you feel that the balloon is quite hard, and you might not need any further, or you might need to add more water. The balloon can take up to 2 liters of water. It's still going. It's still going. Right. So then you should fill the balloon. The balloon is now fully filled with water. At this point, once full, you may remove your hand that's still inside. You remove this hand and you would see the outside tubing loosely to the inside of the thigh. You don't need to pull it tight, just loosely to prevent it from coming out. Okay, now we've got our patient and she's set up. And now we start with the monitoring. Obviously, we will check her vitals, stabilizer, and we will check, when checking the vitals, we also check her blood pressure, of which in this case, the systolic blood pressure becomes important. Because when a systolic blood pressure is between, let's say, 120 and 100, we'd like to keep the percent as high as possible. If a systolic blood pressure is between, let's say, 80 around there, you are welcome to bring your drip stand down. In the IFU, you will find that there's a table. The table gives you a guide in terms of the systolic blood pressure and the height of the supply bed. And it gives you the measurement in terms on meters as well. That's why we spoke on the black rings as well. The black rings also helps you to determine the height of the bag versus the patient, versus the patient. So what we would see is once this uterus is starting to contract, you'll see that the water returns back into the supply bed. So this is just to give you an idea of what it will look like. Can you see the water returning back to the bed? Right. So even at that height, the uterus is able to push the water back into the supply bed. That is one of the indications that the uterus is now contracting, and like Prof said as well, you couldn't find that the uterus expelled the entire balloon. At that point, when there's no further bleeding, you'll be fine. Your uterus is as regained contractility. Is there anything you'd like to add?
Actually, just show the scenario of discomfort.
If your patient, if there's a patient that complains any abdominal discomfort, what you could do is you could lower the drip stand. So I just want to, I think it has been mentioned a few times, but I will mention it again. The higher you place the supply bed, the more pressure you are applying. As you are lowering the supply bed, you are lowering the pressure you are applying onto the uterus wall. At this point, when your patient complains about abdominal discomfort, you can go in and rub, and at the same time bring the level of your supply bed down so that you are applying less pressure, and that will alleviate. For the facilities in the hospital that are referring to the next level of care, you can manage your patient, monitor your patient while waiting for your ambulance. The moment the ambulance arrives, or even if the patient needs to move from the one ward to the next, you can do the same as well. In order to maintain the pressure that's being applied, you can, obviously the drip stand can't go into the ambulance. So what you do is you close the tap. By closing the tap, you are locking in the pressure that's being applied. You take your supply bed and place it next to your patient. And off she goes. She goes to the next ward, she goes into the ambulance. Once in the ambulance, you can also inform agents when they are collecting, and when you hand it over the patient, inform the ambulance as well, that while she's being transported to the next level of care, if she's complaining about discomfort, they can do the same. While in the ambulance, lift the bag as high as possible, open the tap just to release some pressure and rub the abdomen. They can also do it every half an hour just to make sure that at this point we don't have a free flow system, and we want to have a free flow system. So while she's being transported, also every half an hour, lift the bag, open the tap for 30 seconds, and then close the tap again and put the bag down next to it.
I think something, by the way, the purpose of the Ellavi is to stop the bleeding. So after you've inserted your balloon, don't forget to still continue monitoring the patient, because once you have put this, in the meantime, because the purpose is to stop the bleeding, you must still observe what. Once you're observing there, maybe you check your observations every 15 minutes. Clean up the cervix just to check if there's any bleeding, and then the drip stand again, you have to lower it and check again if there's no bleeding. If there's no bleeding, then you're fine. But if the bleeding continues, that is why we say to keep the drip stand still high up at 1.5 to maintain that. It's important not to forget to continue monitoring, because you would not know if the bleeding is still there or it's not there if you don't continue monitoring.